Okay, so welcome to Innovations in Community Care, our 10-week series of brief talks on important topics in community medicine. My name is Dr. Lawrence LeBeau, and I'm the Program Director for the Wright Center for Graduate Medical Education National Family Medicine Residency Program that organized this event. The speakers you hear from each week are faculty members from one of our training sites. And I always say one of our training sites because our program is the only national consortium of teaching health centers that have come together to form one ACG accredited family medicine residency program with osteopathic recognition that operates as a single program with training locations in 4 different states. Our community health center partners are El Rio Health in Tucson, Arizona, HealthSource of Ohio in Hillsboro, Ohio, HealthPoint in Auburn, Washington, and Unity Healthcare in Washington, D.C. If you're a student considering applying for a family medicine residency program, we'd love to meet with you afterwards and answer any questions you have about our program. We have some faculty, and by the time we're done, we might even have some residents on hand from the program who will be available after this talk to take questions. Recognizing that everyone's time is valuable, we want to keep each talk in the series both high value and brief and to the point. The presentation tonight should last about 20 minutes, followed by plenty of time for questions and answers. So with that introduction, I'm going to turn things over to Dr. James Wong and Dr. Will Dixon from our Unity Healthcare Community Health Center partner site in Washington, D.C. for their presentation this evening on medicine for the unhoused. Take it away, Dr.
Thanks,
Wong.
Larry. So I'm Will Dixon. I help to run the program in Washington, D.C., along with James and a few other core faculty here. If you can't tell, I'm the one on the right. But with slightly more wrinkles and gray hair than in that picture. So today we're going to talk a little bit about one aspect of our care at our community clinic, which is care for the unhoused. Next slide, please. So to kick off this, it's worth talking about what we mean when we say homelessness or the unhoused. And so the way that this has been defined by the Bureau of Primary Care is it's someone without permanent housing, and that sometimes that takes the form of something of people that we're somewhat familiar with when we think of homelessness, people who are living outside, but it also includes people who just don't have permanent housing and are living with a series of friends. Living in shelters. And so in general, it's people who, have an instability, don't have a regular place to spend the night, and that can actually take a number of different forms. So to capture exactly what homelessness looks like in DC, each year there's a point in time count. And so on one night, volunteers sort of fan out across the city and attempt to count everyone who in that moment is without permanent housing. And so they sort of check everywhere throughout the city. They look in the shelters and they take a count. So DC, as of January 2021, at this last count, counted about a little over 5,000 people who were experiencing homelessness. That's out of a city of somewhere around 700,000. That was down about 20% from 2020, which is a good sign. Of those roughly 5,000, nearly 4,000 were unaccompanied adults. About 1,200 were families, so unhoused families, and there were 6 children in there. About 700 or so of those 5,000 were actually folks who were sleeping outside in tents or, other places. And so the majority of those people who are experiencing homelessness are not the folks that are sleeping outside and unsheltered. But the number who were sleeping outside had gone up about 4% from 2020. So it's interesting that as the rate of homelessness in the city decreased, the rate of people actually sleeping outside had gone up. Then to look a little bit further about the sort of subpopulations among the unhoused community. In DC, about 40%, a little over 40% have been incarcerated at some point. So there's definitely a link between our previous talks on correctional medicine and homeless medicine. There's having Unity, which also provides care in the DC jail, can be really helpful to us who provide care for unhoused folks, because we often have access to the records of folks in both settings. About 40% have been diagnosed with a medical condition, and 22% have a chronic health condition. My guess is that both of those probably suffer a little bit from reporting bias or underdiagnosis bias, just because folks in these populations often are getting sort of suboptimal healthcare and therefore maybe haven't been diagnosed with conditions that they actually have. About a quarter have experienced domestic violence in their lifetimes. About 4% are veterans of the U.S. Armed Forces. That's definitely improved of late with different legislation that's been passed to prioritize housing for veterans. And about 40% again are experiencing chronic homelessness. So have for a period of multiple years have been without housing. To think a little bit about the interaction between homelessness and healthcare, there are a number of different conditions which are directly caused by homelessness, and that includes weather-related conditions for those, roughly 10% or so who are sleeping outside. That includes frostbite, illnesses that are contributed by heat or too little heat, trench foot, also nosocomial infections, the diseases that people tend to contract in shelters or sort of other congregate living. Violence, people who live on the street tend to be robbed a lot, tend to be subject to attack and robbery, and addiction. There's also conditions that people tend to contract before becoming homeless, which become worse. And there's a whole lot of factors with that. That includes not being able to attend your appointments, not being able to get your medication, the sort of competing priorities that you have of having to manage trying to find a job, trying to find work with trying to manage your health, not being able to get to jobs, not being able to pay for your healthcare or pay for your medicines, and then not having a place to store medicines. A lot of time when people are discharged from the hospital, I see them discharged with medicines like insulin that require to be refrigerated. And in general, a lot of folks who leave with pills end up having those pills stolen or taken from them as they're sleeping in shelters. And so it can be really tricky for folks to keep medicine. So these are sort of all the things that we're interacting with as we're taking care of folks who are unhoused. And homelessness is also like a fairly big health hazard. So the people who are experiencing homelessness, you can see that life expectancy is 2/3 to half of what folks who live in houses will experience at 42 to 52 years. The rates of hypertension and other cardiovascular disease are somewhere between double and 4 times as much as other folks, and they tend to get them at younger ages. And just the general sort of chronic uncontrolled medical conditions that like asthma, COPD, diabetes, each of these things tends to run much higher in the unhoused population. We're also often seeing people sort of in acute crisis situations of where these conditions have become decompensated and people are into diabetic ketoacidosis or hypertensive emergencies and other things because they have these chronic problems where they're not able to regulate them well. And therefore things decompensate and they show up in sort of extreme versions of these chronic conditions.
So thanks, Will. So now, the question was asked, like, what can we do as healthcare providers for people experiencing homelessness? And so one of the main ways is that we lower the barrier to accessing care by bringing our healthcare to where patients are. And the three ways that we do that are through being co-located in shelters, so where people are staying. We have clinics throughout the city at different homeless shelters. We also have a new outreach van that goes to the different encampment sites and to different areas where folks congregate on the streets. And then we also have a walking outreach where people literally go out, like a healthcare team goes out with a bag of medicines, blood pressure cuff, pulse ox, and just walk around where people are staying under like bridges or out by the highway. And so when we think about the type of care that we provide, we follow this model called the PCMH, or patient-centered medical home model. We use this care model within our community health centers, and so we apply the same approach to our clinics with the Unhoused. And so that basically means providing primary care model that's well suited to meet the patient's needs. And so we have care teams that help with, we have a social worker that will help with getting insurance, or if people need a new ID, we have folks that help our patients with that, as well as helping make referrals and coordinating transportation. We even have had community health workers accompany patients to their specialist appointments. And so we're really applying this PCMH model across the patients who are unhoused. And so this is kind of just like a timeline of where Unity has started and has gone to. And so, like I mentioned, we started off in Christ House, which you'll hear about a little bit later, which is our respite house. And then we have CCNV. And so CCNV is unique in the sense that not only is it housed like next to the homeless shelter, but we also have specialty services there. So we have dentistry, mental health, podiatry. So really enhancing the access to specialists has really helped decrease the barriers to accessing healthcare for our patients. And then this is the newest iteration of our outreach van. And so we're able to it has exam tables, we're able to do exams, take blood pressures, even if you had an IUD, we could do that in there. So it's really well equipped. And then I mentioned before, throughout, at the shelters, when we do walking outreach, we're able to take medicines with us. So if patients, if they had their medicine stolen, or if they lost them, or if they're not able to make it to the pharmacy for the refills, we're able to supply at least a 30-day supply for most common chronic illnesses or acute infections or any type of like skin rashes. We're able to provide medicines right on the spot. And then this is just a picture of some of the encampments around DC. The picture on the left is in Noma, north of Massachusetts Avenue, and then to the right is right near the Watergate. And so these are kind of typical encampments that we would just do walking outreach, and really each week the same medical team goes and so tries to build that relationship with patients, because there's a lot of mistrust of healthcare providers. And so it might take a few weeks before patients are agreed to be seen and to like take medications from us. So really it's about focusing on how to build that patient provider relationship. And then really what's, the past year and a half has really highlighted is kind of the health disparities across different populations. And so for folks who are in congregate settings, we started multiple programs working with the city to provide healthcare during the pandemic. And so some of those include screening for COVID symptoms at the homeless shelters, and then referring to what we call ISAC, so isolation and quarantine. And so we were providing healthcare at ISAC. We also helped coordinated with the Department of Human Services, something called PEP-V, so for populations who are vulnerable, so folks who would be at most risk of suffering complications from if they were to get COVID, so people with immunocompromising disease like HIV or chronic multiple illnesses, elderly folks. We were able to house folks in these hotels that weren't being used during the pandemic. And so the city had rented out several hotels across the city where we were able to provide healthcare in these ISAC units and PEP-V. We also, I'll talk a little bit more about some town halls and COVID vaccine events that we did. And so here's a picture of the team at one of our shelters, 801 East, which is a men's shelter in Southeast. So I mentioned the ISAC, so the isolation and quarantine hotels. We were able to provide medical care around the clock since the beginning of the pandemic. And at times we had up to 750 patients during this time. So people were able to safely quarantine and be away from the congregate settings, off the streets, and spend, whatever 7 to 10, 14 days at the ISAC sites to make sure that if they were getting over COVID to fully clear it, or if to spend the quarantine time there. And then I mentioned the PEP-V, so the sites where folks who are at most risk of having complications from COVID, we were able to provide daily check-ins at these hotels. DHS, who's Department of Human Services, was able to provide transportation to people's specialty appointments. We had worked with our pharmacies to deliver medications to the residents at Pep B. And I think one of the ways that we can help, aside from providing healthcare, is advocating for housing, which is healthcare. And so we were able to see, for folks who stayed at Pep B, a sustained decrease, about 10-point decline in uncontrolled hypertension over the course of the pandemic. And I think that makes sense in the sense that, like, patients had stable housing, they were able to take their medications every day, they didn't have to worry about losing their medications, they were given 3 meals a day at these sites. And so we did see improvement in folks' healthcare outcomes. And then eventually we were able to move a good amount of people from Pep B to stable housing. So 237 people during the past year and a half were able to get housing, and then there's an additional 155 matched and waiting for transition to housing. And then another thing that we were able to do was do town halls at different shelters across the city. So basically these town halls were to have 2 providers go and talk to folks about the COVID vaccine and really try to build people's vaccine confidence and answer any questions. And so I'm pictured here with Dr. Colette Harris, and we were at Harriet Tubman, a women's shelter, and people just had, all sorts of questions. And I think, people were able to sign up after the event, and a good amount of people got up during the talk to sign up and afterwards. And so that was one way that we tried to work with the unhoused population to make sure that they were getting their vaccines. And so we held vaccine campaign events at the different shelters across the city, and we were able to vaccinate over 5,000 people and frontline staff who work at the shelters. And so I'll turn over to Will to talk about our respite care program.
So a final aspect of care for people experiencing homelessness at Unity is respite care. And so that's sort of specifically care for folks who are unhoused and are, in going through life circumstances where they really need a stable place to stay for a temporary period of time. So one of those is Christ House. So this is one of Unity's very first locations. It's been around for over 35 years at this point. And Christ House has nursing care in the house for 24 hours a day. There are 34 beds there. Christ House is only for men. Pat Handy is only for women. And so the sort of people that are seen there are folks who are without stable housing and need a place to stay for a while. So, I've had people who have a very serious infection, something that is sort of falling short of hospitalization, or maybe are being discharged from a hospitalization and need to are not safe to return to the street. And therefore able to stay there for a while. And within there, not only is there medical care, but there's in-house mental health care. There's social services to help folks try to transition to a safer place. There's addiction services to work with sort of comorbid addiction issues, and there's pastoral care as well. So last year, there's 140 total admissions. Each of those stayed on an average about 39 days. So folks are staying for over a month on average. These are generally pretty sick folks who need a lot of care. You can see that 7,122 total days of patient days spent there last year alone. And then just like with Pep V, as James was explaining, Christ House is another place where we've tried to use the opportunity of having folks in one setting where we can reach them repeatedly to try to address some sort of other chronic problems. So, for example, we worked on lung cancer screening in folks last year, and of the 50 patients there, 49 of them, we interviewed them about lung cancer screening and got them all referred for the low-dose screening CT scans, which is part of the USPSTF guidelines. We educated them on tobacco cessation in weekly interventions with nursing staffs, and we have standing orders in place so that the nursing staff can sort of directly give nicotine replacement therapy. And then all patients who were there were offered help with scheduling COVID-19 vaccination. The other site is Pat Handy. So Christ House is only for men. Pat Handy is a site only for women. And again, it's for folks who are going through things where they're sort of too injured to be safely in the shelter or outside environment. And that includes things like the conditions that you see right there. A lot of times it can be really helpful for folks who you're trying to coordinate some part of really complicated care for, and them being in the street makes that care hard. For example, if there's a few folks that I care for who are unhoused, who are going through, who need a colonoscopy, for example. Like, I've gotten them a fit test, it's come back with blood in it. And to be homeless and to have to do a prep, to have to take medicines, like for a bowel prep, is basically impossible. It means that you sort of have to have a toilet available for 12 hours, and that's just nearly impossible. And so Pat Handy and Christ House are both sort of helpful for being able to get someone that sort of temporary housing as they're going through a procedure. And again, so Pat Handy and Christ House are sort of both places where people can get that sort of intermediate care when they are not housed. So those are the sort of different cares that we have for the unhoused at Unity Healthcare. If you come do residency with us here, you'll get to do that as part of your community-oriented primary care months that Dr. Wong helps to facilitate. And if you have any questions about that, feel free to reach out to me or Dr. Wong. Both our emails are right there. Any questions that anyone has? Angelo or Anam or anyone about care for people, unhoused folks at Unity Healthcare?
I think, like Dr. Dixon was mentioning at the end, I think just like the unique opportunity that we have, and then many of our residents, because they learn, they're able to then make this as part of their repertoire after they leave, and to seek other opportunities to practice medicine and feel comfortable with patients who are unhoused. So I think, the more you get in training, the more that you're comfortable with doing things after. And so I think the curriculum that Dr. Wong and Dr. Dixon have set up now are really exceptional, and it's hard to find that in residency training programs. So I was really thankful for being able to do it.
Yeah, it's a great pitch, Anam. And yeah, it's something that's somewhat unique to being able to train in a community health setting, is that you're able to work with these sort of communities. And I think, as you're saying, I can think of 2 or 3 residents who go and serve folks in the unhoused community as part of Unity's, the different programs that Dr. Wong was talking about.
I was wondering what some of the challenges are with first seeing a homeless patient for the first time. What kind of conversations do you have to have with them, and how you can get them to trust you and get them to come back to you for care?
What a great question. Yeah, there's a lot of them. James, do you want to take a swing at that one?
Sure. So I think it's first, kind of with almost any other patients, just sitting there and listening, and just really hearing what they're saying, and asking for, and really trying to build that relationship. And so you might not get anywhere on the first visit, but the way that we have things set up is that we're consistently going at the same time, same day each week, and folks get used to that. And when they start seeing that you're committed and keep coming back, and then you start to build that relationship and trust.
And there definitely are sort of logistical aspects to it too. So yeah, I definitely agree with James in that it tends to be a population that it has a sort of high resistance to authority, or low trust in authority. And so it means that you have to sort of show up and listen, and listen especially hard in order to get buy-in for the treatment plan. But there's also sort of the logistical things, like we talked about, knowing which insulins are the ones that don't need to be refrigerated, trying to figure out the sort of workarounds to folks who might not have a safe place to stash their medicine. And so it requires quite a bit of creative thinking that you don't necessarily have to interact with in the office.
Yeah, and I'll just add too, it's not necessarily that you're the target of their distrust or mistrust. It's because of their prior experiences or interactions with other healthcare providers that might have not been optimal, because a lot of times people have come with or they have come with bias, especially for people who are unhoused, and so they might feel like unheard or mistreated if they go to the emergency room. And so it's really those interactions with other parts of the healthcare system that might build their or take away their trust or confidence in healthcare. And so and then the other point I think is, there's something called trauma-informed care. So a lot of our folks who are unhoused have experienced a lot of trauma in their lives. And so really kind of taking this trauma-informed care approach can really help address some of the communication or and understanding of where the patient is coming from. And so that's another way to kind of frame the interaction, is kind of taking a trauma-informed care approach.
Yeah, that's perfect.
So I know you discussed kind of solutions for addressing people who are homeless already on the streets. Have you thought of things that would be used to kind of prevent that? If you're sensing or thinking that a patient might be soon becoming homeless?
It's a great question. So, working at Unity gives you a couple pretty unique opportunities to prevent that. As we talked about, a good 40% of folks have been through the DC jail system. And so we have some opportunities in working with folks there to do discharge planning to try to get in the way of that. And then because many of the folks who've become unhoused in DC have either been our patients as adolescents here, and there are patients as they're in the process of losing their housing. Unity Healthcare is sort of embedded in all the different communities within the city, and so being able to screen people during visits for housing instability, which we do routinely, for example, as part of initiating pregnancy care. That's one of the questions I ask all the women on my first pregnancy visit, of get a sense of how long they've lived in their house, whether their papers are on the lease, whether they're having any trouble with rent. And we have social services that are embedded in each of the centers that can try to help people to navigate those situations in which they might lose housing.
And I think also another thing would be the opportunity to have a medical legal partnership. So we have a medical legal partnership focusing on other issues, especially in the pediatric population, but that is an opportunity that we could build partnerships with other law firms or lawyers to have advocates at the health center advocating for for people keeping their housing, or if they're having issues paying. So having that partnership would definitely help. And then I think, as Will mentioned earlier, there's an overlap of mental health illness and homelessness. And so, making sure that folks are connected to, we have core service agencies in DC that help address, provide wraparound services for mental health issues. And they are, provided a caseworker and offer other support. And so I think just making sure folks are connected to the resources that are available.
Great questions.
Yeah, thanks. Probably one more question.
Please, as many as you want.
Yeah, as an undergrad, before medical school, I did a lot of volunteer work with Habitat for Humanity and working with my hands to help build homeless shelters. I volunteered at the Soup Kitchen to kind of reach out and get face to face with a lot of these homeless people who are on the streets. And obviously going into medical school, I want to figure out a way to how I can kind of expand my ability to help them or help homeless people. What are some things that you recommend, or things that you did during medical school that you were able to do to kind of reach out beyond just the normal volunteering?
Sure. I think looking for opportunities, sort of asking for opportunities as you're entering your clinical years about whether there are chances to do different rotations in sites working with the unhoused. I happen to know that in your school, Aaron Allgood, I think, has a couple programs there, and so that you could, and they have a elective rotation during third and fourth year where you can do work specifically with the unhoused. One of our current third year residents did that rotation when he was a fourth year student at your program. So that's a great program. But in generally, most a lot of places you end up especially if you're in a city, will have some sort of rotations there. And then there may be a sort of volunteering opportunities that you can do in addition to school.
Yeah, then I think like another avenue it would be through kind of like advocacy and kind of like policy, getting familiar. I think as physicians, we have a powerful voice in our community and in with our elected officials. And so as a student, you could probably, I think AMSA or some other like medical student organizations that help develop those skills around advocacy and lobbying would be a huge help, as you progress through your career and thinking about how we can impact, these issues on a larger scale. And so that, and through advocacy and health policy would be another route as well.
That's a great point.
Well,
Right.
I think I'm good for now. Thank you so much for answering my questions.
Yeah, thanks so much for attending.
Yeah, and I'll definitely look into this program and keep it in mind as I learn more about different programs.
Great, glad to hear it.
Thank you.
Yeah.
Give our best to Dr. Abadi and co over there.
Yeah, for sure.
I will thank you to our speakers and those who have joined us. As a reminder, all of these sessions are recorded and available for viewing or reviewing afterwards on the Wright Center for Community Health YouTube channel. I put that link in the chat box. It's also on the last slide here of the presentation, as well as just a link to the Wright Center's website where you can get more information about all their residency and fellowship programs. So thank you for joining us. Please join us next week on October 6th, when we'll have Dr. Gayatri Menon from our HealthPoint Community Health Center site in Auburn, Washington, presenting on osteopathic practice in the FQHC setting. Thank you for joining us. Have a good evening, everyone.
Thank you.
See you, folks.
Thanks, y'all.